If a patient is not capable of making any decision, the patient should still be in the room when you are making the decision. Okay. So this is what they're talking about. If a patient found an incapable expressing a willingness to pursue the proposed treatment intervention, then this is basically an assent rather than the consent, which requires a capacity. Agree. So again, I was talking about this consent, where our 8-year-old boy understand his condition, he can give a consent as well. So as you can see, the four elements, this can be asked in the scenario that what are the four elements of the consent. So what are those ones? It should be voluntary, it should be capable, it should be specific, it should be informed. Okay. So voluntarily, like they should do it without pressuring from anyone. Capable, they should be understanding what the condition is, what are the consequences, what are the side effects, benefits, everything. Specific, it should be regarding that, like, it shouldn't be regarding like lymphoma, it should be regarding that Burkitt lymphoma. Specific. Okay. Informed, it should be like told and asked properly what the thing we are going to do. If it's an appendectomy, you have to explain what is appendectomy, and then we are going to do that. Okay. So then, however, the patient opting for the care, so I'm talking about this one. So agreement or disagreement with the medical advice does not determine finding of the capacity. Okay. Patients opting for the care that pulls them to the risk of serious harm that most patients would want to avoid would have their capacity carefully assessed. So, like in the cases like, yeah, let's go with appendectomy. If a patient wants to avoid appendectomy for appendicitis, where everyone wants to go for that surgery, now in that cases you have to be very careful to check that, if that person is fully capable of understanding what actually appendicitis is. That's what they're trying to say. Steer clear from the tendency to define what reasonable person standards may be. If appropriate, look to discern patterns of the justification offered by the patients and their individual values and then beliefs that must be influenced by the social context, such as culture or the religion. Law pertaining to the consent and capacity may vary by province, territory, and then readers are encouraged to consult the provincial territorial guidelines. Then again, this is basically PSO or policy for the consent. Capacity. Capacity is a essential component of the valid consent. So they should understand what they are saying and what they are going to do. Again, then we are talking about the professional consideration where you go for geriatric patient and pediatric patient. So geriatric is identify the goal of care. Like you have to, like every 60, 65, not 60, 70 plus patient come for, we always discuss their resuscitation, CPR, DNR, like ask them to fill up those forms and see what they're going through. Checking for the documents of advanced care, like if they ever get hospitalized, in that case says what they want to do, or that, you know, what they want to do in that case is like what's their advanced care of the settings, like advanced directives, what they want to do if they were not able to make the decision. Then comes the pediatric patient. In that ones, identify the primary decision maker, if applicable, like parent, guardian, wards of state, or emancipated. Then the regarding the capacity assessments, usually this says for the pediatric one, if they are able to understand, they can make their own decision. But hardly it's someone that can understand. Be aware of the custody issues if applicable, like mom, dad, mom is having the custody, and mom is making the decision, and dad is there to conflict. So in that case, you have to listen what who has the custody. Okay. Terminally ill or the palliative patient, consider the spikes, like how do you going to breaking the bad news, identifying the patient goals of the care, like disease symptoms, identifying the whether an advanced care plan exists, then determine the patient's SDM, what they want, all of those ones, and then CPR, DNR, what they wanted, like if they had filled up any documents for that one. Now comes to the incapable patient. What are the incapable patients? Incapable patients are those patients who are basically not able to make any decision. Incapacity is treatment specific and time specific. An incapable patient is only incapable for the specific time. So if he's not able to make the decision now, maybe in future he will be fine. Like how maniac episode is. They stays in mania episode they are not able to make the decision. But in other times when they don't have mania, they are able to make the decision. So you don't have to assume that this is lifelong. If not already present, perform a formal capacity assessment and thoroughly document. Identify if the patient has an STM or their primary care of life, and then locate it if applicable. Then check the patient's chart for any mental health form like Form 1 where they were admitted against them. Now we are talking about the 4 elements voluntarily, that there should be no pressure from anyone. Consent must be given free of the pressure. The physicians may not be deliberately misled the patient like, oh, you should be doing this, you should be doing that. No, you should let the patient decide. Physician must engage in the self-reflection prior to entering the conversation. So you should be thinking about how to approach that patient regarding their position of the power and privilege, such as taking the measures to mitigate the power differentials. Then capable, how much they are capable. The patient must be able to understand, appreciate side effects, benefits, everything about the condition. Then comes a specific, that it should be according to that particular disease. The patient must be informed that the students will be involved in providing the treatment. Okay. So even like, there will be a resident, there will be a this person, like we will be working as a team, and this will be there. So in that case, you have to tell them like who will be involved and what kind of treatment you are going to give, and how it's like everything should be specific. So a question can come, especially I think in the ASQ bank, they do like to ask in the ethics point of view, like a resident wanted to participate. In that case, is how will you do? So basically, you have to inform the patient that resident will participate in that particular surgery. Okay. Then comes the informed one. Sufficient information and time will be provided to allow the information to make choices. So let them know the nature of the treatment, the risk, benefits, disclosure, adverse, alternative treatment, declining the treatment, and answer to any question. The reasonable person test, the physician must provide all information that would be needed. Okay, whatever they ask, don't hide anything. Is the physician responsibility to make the reasonable attempts to ensure the patient understand the information. Then physicians has the duty to inform the patient of all legitimate therapeutic options and must not withhold any information. So that's what we're talking. Okay. So you should inform everything in short. So here it is basically, is this a treatment? No, use common law. If this is a treatment, is this patient capable to make the decision? Yes. Then does the patient consent? Yes, treat. Does not consent, then do not treat. Now, if they are not capable to make the decision, is this an emergency? Yes. Is there SDM available? No. Treat it as an emergency and go with that. Except for if there is a Jehovah's Witness. Is this an emergency? No. Discuss the involvement of SDM. Does the patient dispute of identifying of incapacity? Yes, then review the board. Like board members, they will sit together. No, does the SDM has consent? Yes, the consent, yes, treat. If he does not have, no treatment. So did you see how you are, after even SDM, you have to make sure whatever he's saying, it should be aligned with that. Then obtaining the legal consent. Legal consent is basically written consent and the verbal consent, both of them. A signed consent form is only the evidence of the consent. It does not replace the process of obtaining a valid consent. The most important component is that the patients understand and appreciates not what the signed consent from the states. So like, let's suppose if someone gave the consent, a written consent, and now they came and then they give you a verbal consent, like a new verbal consent, and he's fully capable of that one, you will follow that. Okay, although there is a written consent. The most important consent in what the patient understands and appreciates, not when the signed forms, consent form states. Then there is an implied and then express consent. Consent is an ongoing process and can be withdrawn or changed. As I said, it can be changed in anyone. What is the would we assume consent is given? If the SDM is not sure, we will not assume. Okay, if it's an emergency, we will treat. If it's not an emergency, we will hold and see what the patient wishes was in the previous treatment, or what's the patient wishes what for the different kind of treatment before he has done. Like I was talking about that appendix, right? If the patient had, let's suppose, tonsils and he had a tonsillectomy, and now SDM is not sure if he want to go for appendectomy or not. In that cases, now this is an emergency situation. Since he had tonsillectomy, we can think, because SDM is not sure and this is an emergency, we will do appendectomy. But again, if it's just some sort of inflammation going in abdomen, but not appendicitis, and it's not something that needs to be surgery or an emergency right away. In that cases, he did tonsils, but STM is not sure. So in that case, we will not do anything. We will start IV antibiotics. We will not do any surgery. Okay. If the consent has been withdrawn during the procedure, the physician must stop. Like, in the middle of the surgery, if the patient has local anesthesia, he said, stop, will stop. Although it does not make sense, but yeah, you will stop right away. So consent is an ongoing process and can be withdrawn or changed at any time unless stopping a procedure would not put the patient harm because the patient is not informed or incapable. In obtaining consent to continue the procedure, the physician re-explain the procedure. Re-explain the procedure. So if someone is not sure, he signed the consent, he came back, he asked the questions, you have to re-explain it. Okay. And risk and benefits and obtaining the originally, if there is no material change in the circumstances, simply assent. It's a very important thing to make a proper concept about the consent. It should be like those four things: voluntary, implied, simplified, and all that. So please, they do like to ask about the resident point of view, like a resident wants to be participate, that resident wants to do that, because they are someone, they are not sure of what they are going to do. So in that cases, if possible, if there is a question, option of reviewing with the supervisor, talking with the supervisor, talking with the patient, so go with those ones. Engaging, asking more questions, those are the answers. Okay, don't make decisions if you're not sure. Exception to consent. Again, we are talking about emergencies. Emergency makes sure that there is an implied consent. Treatment can be provided without consent when the patient is experiencing severe suffering. When a delay in the treatment would lead to the serious harm or death, or consent should not be obtained from the patient. Emergency treatment should not be violate a person's express, like if they have a Jehovah's Witness card, or they have a signed Jehovah's Witness, and or they are Jehovah's Witness. In that cases, you don't give them blood. Okay. If the patient is incapable, the physician must document reasons for the incapacity, why situation was emergent. So they have to write down he came with the pain, fever, his lactic acid was very high, he was having a small bowel obstruction. If I did not do it, he would have ischemic necrosis or whatever going on. So you should write down. Patient have the right to challenge or finding of incapacity, and it removes their decision making ability. So in that case, if you have a written consent or written forms or written papers or documents, in that case you can provide those ones, so it will help you. If a SDM is not available, the physician can treat without consent until the SDM is available or the situation is no longer emergency. Again, then comes the legislation. Mental health legislation allows for the detention of the patient without their consent. Of psychiatric outpatients may be required to adhere to the care plan in accordance to the community treatment. Like if a depression person comes with a slit uh, hand, you have to treat them. Public health legislation allows the medical officers of the health of the to detain, examine, and treat patients without their consent, like TB. It can be spreadable, so that's why, to prevent its transmission, like chicken pox, polio, rotavirus, those things. Specific situation is basically public health emergencies, any epidemic like COVID-19 or those things. Warrant of information of the police, like gunshot wound, all those, or stab wound. Consequences of the failure to obtain a valid consent, what could happen? Obviously they will be liable, and legal consequences plenty for all those ones. Overview of the capacity. So capacity is the ability to understand the information, making the proper choice, appreciating the reasonable foreseeable consequences of the decision. Capacity is a specific for each decision. A person may be capable to consent to have a chest x-ray but not for bronchoscopy. Okay, so they should be very specific. Capacity can change over time. Okay. Most Canadian jurisdiction could distinguish capacity to make the healthcare decision from capacity to make the financial decision. So, they think like if someone is capable to make the financial decision, they will be able to make their health decision. So that's how they deal with that. A person is presumed capable unless there is a good evidence to the contrary. Capable patients are entitled to make their own decision. Capable patients can refuse the treatment if it's like, serious harm and all those ones. Assessment of the capacity. So there's still a lot. So from assessment of capacity, we'll do it from tomorrow. So let's do some MCQs. So there is a question here. Question one, a phase 3 drug trial is conducted to examine the efficacy of a new drug, anacatrapib, to provide a protective effect among the individuals with atherosclerotic cardiovascular disease. Phase 2 data suggests that the anacatrapib suggested significant raises HDL level relative to the both placebo and rovastatin. Then they were saying preliminary data from the phase 3 is given. Then treatment, mean HDL is this one, and then anacatrapib, atorvastatin, and then placebo. And ANNOVA revealed no significant difference in the mean HDL level between the treatment groups upon re-examining the data. Following results are here. So treated among the people and among the men and women. What can be said when the relationship between the anacatrip and the mean HDL levels? So the MCQs are anacatrip significantly raises HDL level in men. Anacaprib is never effective at raising HDL level. So let me just see if we have an answer. Yes. Anacatrib is superior to placebo 3. Gender is an effect modifier, and the gender is co-founder. Did you see? The whole scenario did not make sense. Okay. Now we are coming back. Like, I'm just letting you know how to, deal with this kind of scenarios. So I'm not sure if it'll be right or wrong, but I'm just giving you an idea about how to do that. So first of all, you need to read, like if I am the person who is going to deal with this scenario, I have to read the last line first. What are they asking? So they're asking about what can be said about the relationship between this thing with the mean HDL. So if we see with the mean HDL, how much this one? 41.5. Treatment among the patients HDL is 47.9. And then in this one, mean is basically 41.3. So in women, it was 47.5, the mean HDL. And in this one, this was 41.3, and this one overall was basically 41.5. So this says how much it is the relationship between that one. So if you compare with the other ones, atorvastatin has a significant difference, especially in the men, it has 39.8. Then the placebo has the similar one, but mainly in the women, they had a better effects. So if you can see, they're talking about significantly raises. So we did not see. So they were talking about the relationship. We did not see any significant raise. This was the normal one. So did we see any significant raise? So I think this in women, they do have a significant little bit raise as compared to the other ones. Then they says anacaprib is never effective at raising HDL level. This was pretty much like, there is a little bit difference. Then the superior to the placebo, gender is the effect modifier, and the gender is the co-founder. So what do you think about this one? I think in this one, the answer could be this one. A is not correct because for me, I'm thinking the gender could be the problem here. Okay. So let's see, the answer is basically the correct answer is D. Why? The gender is the effect modifier because as you see, it was getting higher or lower, but not in both of the cases. This says anacaprib raises HDL level in men. It does not raises in men. Then again, is never effective at raising HDL. It was effective in women. Then anacaprib is superior to placebo 3. Then it was in superior in placebo 3. No, it was not. Then gender is the effect modifier. Yes, because in women it was little bit higher, and then in the men it was not. Okay, so that the gender is co-founder. No, it was not, because in the woman it's different, in the woman man it's different. So we have to know both of them. Okay, so that's how you make the difference. Like how you approach the scenario, it's very important. So you read the last line and try to go, like if you read from the top, maybe it will not make sense to you. But if you read the last line and go with the options and try to fit the options in the scenario, that will also help to solve an MCQs. This is another way of solving an MCQs. Okay, so this can be used in the exam. I just told you how to, solve it, like giving you some example. Okay. So why A is not correct? So you can see anacaprib is in the man, it was stated different, and then anacaprib does not. So you can read all of those ones. We will not this one. Then go into the next one. A 15-year-old girl comes to her physician office concerned that she may be pregnant. Her last menstrual period was 8 weeks ago, and she has not been using any protection with her boyfriend. Before the physicians order the beta HCG test, he has a long discussion with the patient about her current social situation. Which situation warrants breaching the confidentiality between the physician and the patient? Which one? Beside being concerned that she may be pregnant, the patient also says that she has been using cocaine for the past year and wants to seek treatment without her parent finding out. So, do you think cocaine should be the one that should be revealing? For me, no. If she is pregnant, the patient is worried that when her parents find out, they will not let her see the obstetrician gynecologist for her choice for the care during the treatment, but will force her to see her mother's ob-gyn. So do you think this can also be the one that can help you to breach the confidentiality? The patient says that when she told her boyfriend she might be pregnant, he lost his temper and starts screaming that he would not use any means necessary to ensure that the pregnancy is terminated. And then the patient says that several months ago, she went to another physician who diagnosed her with a chlamydia infection. Her boyfriend was aware of this, but she's scared that her parents will find out. The patient says that she would like to obtain condoms from the physician before her parents would go crazy if they knew that she had bought condoms. So, in which cases breach warrants breaching the confidentiality between the patient and then physician? Which one do you think? Sorry? So D, okay, someone said D. The patient says that the several months ago she went to another physician who diagnosed her with a chlamydia infection. In that case, the situation warrants the breaching of the confidentiality. Let's see. So reasons to breach confidentiality: communicable diseases, the child abuse, vulnerable adults, driving, flying and tram, the marine safety, then fitness to work. So they have written even more of those. Gunshot wound, management of the healthcare and duty to inform. So A is not correct, B is not correct, D is not correct, E is not correct. So C is the correct choice. So they're talking about the harm of that one. C, because they says that he will terminate the thing. So in that cases you have to see the safety of the patient. It was a previously diagnosed chlamydia, like another physician previously diagnosed, not now. They're talking about in this case scenario. Okay, they're not talking about the previous one. In which case scenario they said, like, read the word, which situation warrants breaching the confidentiality between the physician and patient, between this physician, between you and patient. Okay, so in which cases, like if they break to the mother, if they take her to the ob-gyn, obviously this does not make sense. Whichever ob-gyn she goes to, cocaine, that's her personal choice. It does not have to do anything. Then chlamydia was a previous thing. And then the condom is also something that it's not gonna affect their parents. We are talking about here the beta HCG. So if the beta HCG is affected and causing the termination or like scream and all of those ones, lost his temper and maybe he will try to harm the mother, in that case this is basically an injury point of view. So that's what they're talking about. Let's go with a little detail. The relationship between the doctor and patient is care, and why not that one which you said, the chlamydia one here. Fortunately, this patient's sexually transmitted infection has been treated. However, even if she were to present today with chlamydia, okay, if it was today's episode, then nobody else, including her parents, would need to find out. Okay. So usually in STIs, we don't inform the partner, we do inform the public health. Okay. So then this says post great harm to herself and someone else, the physician may break the confidentiality. Again, we are talking about a 45-year-old man comes to the office because he wants to be treated for HIV. Further questions reveal that he has read the result of her new cohort study on HIV transmission. He states that he has been exposed to almost every one of the risk factors listed in the article. Which exposure is statistically significant of increased risk of the disease? So exposure risk number 1, 2, 3, 4, relative risk, how much is the relative risk, and then confidentiality, this one, 95%, which one is closer to that one? So the answer is E. How? So you can see all of those ones, okay? The study of aspirin for the secondary prevention is coronary artery disease, where the was recently completed. The treatment group has been 400 patients, of whom 40 has a myocardial infarction. The control group has 400 patients, of which 80 has a myocardial infarction. Which are the following? So you have to make 2 by 2 table. Okay. So they're asking for number needed to treat. Okay. So the formula for number needed to treat. So they have given you this 2 by 2 table. So everything is already in the answers. So you don't have to worry about those ones. So number needed to be treated is basically 1 divided by the absolute risk reduction. So how do you calculate the absolute risk reductions? Basically 0.2 minus 0.1, and then how do you calculate it? Okay. Then we are talking about this one. So just for me, I feel like if you read the last line, okay, and then do the first one, it is more easy. Why? Because now you understand what they are asking and what you have to look into the scenario. Believe me, it will save you a lot of time. So I always try to do that one. I don't know how it works for you, but you should try to do this thing as well and see, because last line can help you to figure out what you are looking in the scenario. What kind of study is this? So now you have to read this one and find out if it's a case control, case study, cohort, randomized chart review. So I will not read this one to save time, okay? So you can read this one. Then again, they're talking about this one now. If you see this one, they are talking about positive predictive value of the echogenetics. So they have everything given. If you don't even read this one, you can solve it from here, okay? So the positive predictive value, how the formula is and how you calculate it. In the next one, which of the following bias did the company fail to account for? So if you read how much it was, then received, and this one happened, the drug company concluded that the new drug is twice as effective to the pancreatic cancer compared to the conventional treatment. So it could be this one. So the answer is B. Again, this what kind of study is this one? So you can read this one. So I'm just trying to save time so we don't have to go into very detail of it. Everything is written all the answers and is thoroughly explained in the answers. Then again, what time of is accurate with regard to the conclusion of the study? So which one is good one? And then they have given everything here. Again, this says what amount of the risk is attributable to having a parents who are experiencing the stroke before the age of the 65. So what is the likelihood ratio? Okay. So again, they were asking about the type of study. So I will just share these slides with you. I think you will be able to do it. Try to do it by yourself and see if you are not able to understand anything, you can always ask me. Okay. So then again, this one. Yeah, I was thinking if there are some of the ethics question, but no, they don't have ethics question in this one. Okay, I do have some other slides for ethics, so we will do those ones. Okay. I just have to, okay. So all of them, these are epidemiology. So try to solve these ones by yourself. Just thinking if there are some any ethics question in these ones. No, they all are the case control and cohort study one. I mean, this is very important, okay? So we were doing this one here, assessment of the capacity. Assessment of the capacity is basically how you're going to assess the patient. Again, we are going to do the MOCA, MMSC to check for their mental state and everything, but that is mainly for their dementia, okay? So don't mix these things. So the person undergoing the assessment of capacity must be informed that they will be assessed. Capacity assessment must be concluded by the clinician providing the treatment if appropriate in consultation with the healthcare professionals like another physician interprofessional. Then clinical capacity assessment may include the specific capacity assessment. Then effective disclosure of the information and then evaluation of the patient reason for decision. Then understanding of the condition, treatment for benefits, side effects, accepting and all those. For the appreciation need for the decision-making capacity, acknowledging for the treatment, how to be various decisions, options, how to go with which choice. General impression, and then the aid to capacity evaluation. Then who do the decided? The capacity review board. So that's what they said. If someone is not capable to do anything, you have to go to and review the board. Okay. So they do that one. If incapable to review the capacity and consent review board, the patient may receive notice of their ability to pursue the judicial review. Then the treatment of incapable patients is not an emergency situation. How do you deal with that? Obtain informed consents from SDM. An incapable patient is basically document assessment in chart, notify the patients of the public about the mental health problem, and notify the writer's advice. So you have to notify two people or two things before going with STM. Okay. So document it. Obviously, documentation is something that you have to do with everything. Okay. Second thing is notify. And notify who? Mental health. Then the second one is notify the rights advisor. So when we are talking about documentation, even if you do a very minor procedure, if you do anything, and in the scenario they ask what was the next thing, or in the scenario or the options there is like documentation, the documentation is the answer, because that's how you are going to challenge it in the court. Or if they ask you that you are negligent or liable for any kind of misconduct, and then patient is suing you for anything, and you are in the order or called in the court, in that cases how will you justify yourself? So in that cases, you have to bring your documentations. Okay. So no, nothing, whatever it is, like, calling the seniors, colleagues, asking for whatever it is to, those ones like nurses was there, this one is there, like, like and witnesses and everything. No, witnesses and everything will work, but the main thing is documentation. Okay. So the answer is documentation. That will save you. Then comes the substitute decision maker. It should be the wishes unknown. So he has to follow the patient's wishes. If wishes unknown, in that case, is value and beliefs held by the patient with capable. Then well-being is basically improved with or without treatment when the expected benefits outweigh the harm. And less intrusive treatment must be the beneficial one. The final decision may or may be challenged by a physician. Okay. Then the instructional advanced care planning, I think it's planning, allow the patients to exert the control over their care once they no longer capable. The patients communicates their decision about the future healthcare, including who they would like to make the treatment with. So to use the patient is incapable with respect to the treatment decision, then in Ontario, patients can appoint a power of attorney for the personal care to carry out their advanced directives. So a legal, like this is basically in Ontario, so you don't have to go into very detail of the province wise. So they have a power of attorney, they do so sign those ones. Patients should be encouraged to review their documents with their family and the physicians and to evaluate them to ensure that their safety, they reflect their current wishes, what they want now. Okay. So then on the sidebar, this says many provinces have legislative hierarchies for STM, and then how this is Ontario for. Other types of capacity hot covered by ACCA, the testamentary, fitness, financial, personal, and then substitute. If there is no, just one thing here, if there is no medical capacity thing available, then you can always check for the financial one. And if there is a financial assessment available and you know that this one he wanted for something, then in that case you can go along with that one. Or if he has given financial capacity to someone, like there is no substitute decision maker, but there is someone of his financial supporter or who is dealing with his finances, that could be his substitute decision maker. This could be asked too. Okay. Then comes the power of attorney. All guardians and attorneys have the fiduciary duties for the dependent person. So power of attorney for the personal care, which one are those ones? Healthcare, nutrition, shelter, clothing. So who have they appointed for those ones? Guardian of the person, someone who is appointed to the court to make the decision on behalf of those ones. Then continuing power of attorney for property, legal, documents in which the person gives another the legal right to take care of their property. Then guardian of the property who is appointed to the public guardian and trustee or the courts look after the capable person's property, then the public guardian and trustee acts as SDM, like substitute decision maker of the last resort on behalf of the mentally incapable person. Then the pediatric aspect of the patient capacity covered. How do you do that? No age of consent. That's why I said 8 year, 5 year, if they are able to understand, they can make it that decision. Okay. So it says in the all provinces and territories except for Quebec. Okay. So we don't go with the Quebec anyway. Quebec has a specific consent that infants and the children are assumed to lack mature decision making. So we assume. But if someone is more capable and they can understand, then they can go for it. Adolescents are usually treated as adults, so they will follow them. Preferably, assent should still be obtained from the patients, and even if not capable of the giving consent, in the events that the physician believes that the SDM is not acting in the physician's best interest, an appeal may be made to the local child welfare authority, so you can make the CAS and all that. Under the normal circumstances, patient have the right of the assess the children's medical health record. There is no age of consent in the Ontario, so you can go with that one. Okay, so we'll start with negligence tomorrow, and I do have some of the notes for the ethics, so we'll do those ones. Okay, and if you want to do anything other topics, just do let me know before class so we can do those ones too.